Good morning. Welcome to Friday Medical Conference, sponsored by the Western Montana AHEC. I'm Elizabeth Paddock with the Family Medicine Residency of Western Montana. We're extremely pleased to have Nick Blake here today presenting the clinical utility and evidence for point-of-care ultrasound. Nick is one of our fine third-year residents with the residency. And he grew up in a rural town in Western Oregon. He attended Oregon State University for undergrad, then Oregon Health and Science University for medical school. Between undergrad and now, he did many Oregon things, including working in a lumber mill and making organic goat cheese. After undergrad, he spent time traveling internationally and did extensive couch surfing to become a well-rounded person. So we're pleased to have him here and look forward to all that he can share with us.
So I do tend to mumble a lot, and now you can hear my mumbling. I think that's the purpose of it. So as Dr. Paddock mentioned, I'm talking about point-of-care ultrasound today. A little bit tongue-in-cheek here with the stethoscopes are for checking reflexes, but we'll talk about that more. Brief outline here. So just we're gonna define it. Talk briefly about some of the uses. I'm gonna make some comments on the physical exam. And kind of the limitations of the physical exam. Talk then more in depth about some evidence for point-of-care ultrasound. This is evidence that primarily comes from actually several decades of use now in the emergency department, as well as critical care. Talk a little bit about just sort of utility broadly speaking, and then touch on what we're doing actually in our residency to help facilitate learning point-of-care ultrasound. This is not a talk about how to do it. If you want to learn that, go elsewhere. So disclosures, I have none. I'm not a radiologist or an ultrasound tech, but that's the whole point. If you are a radiologist or an ultrasound tech, you are, by definition, not doing point-of-care ultrasound. So before we get too far, I just want to throw this definition up there. It's defined as goal-directed. It's bedside ultrasound performed by a clinician to answer a specific diagnostic question or to help with an invasive procedure, whether that's central line placement, paracentesis, thoracentesis, something along those lines. In my mind, sort of an extended physical exam, and we're going to talk more about that. I'm just curious, though. I got to make this at least a little bit interactive, but who here would, without really knowing more about point-of-care ultrasound, would say they use point-of-care ultrasound in their practice? So a lot of people, which is good. Here are a few of the uses. This is not a complete list. I mean, you can see up here there's OB-GYN, pulmonary trauma uses, cardiac, and again, this is not a complete list. I actually just learned from one of my co-residents who did a presentation on rheumatoid arthritis that now there's data supporting using point-of-care ultrasound to actually monitor response to DMARD therapy, and it's nearly as good as MRI. So, and that's not on this list. So there are many, many uses. Most things translate well to point-of-care ultrasound. You know, I think it's highly variable depending on sort of skill level. For example, appendicitis, I think, is a very challenging exam to do. However, it is the preferred method in peds population. I mean, ultrasound is. So, and before I continue on and impart my more of my bias, I did want to just throw a critique up there. It says, notwithstanding its value, I'm extremely doubtful because its beneficial application requires much time and gives a good deal of trouble to both the patient and the practitioner. I would summarize this as it's a pain in the ass. I don't know that that's a valid critique, and we'll come back to that later on. So why ultrasound? Many reasons. I wrote down a few terms here. It's dynamic, it's real time, it's an extended physical exam, it's free, it's non-invasive, there's no radiation, and there's good evidence to support it. It's also a really good tool in resource-poor settings. And I think we could argue that to some degree, Western Montana, especially the sites we rotate at as residents, would fall into that resource-poor setting. You're not necessarily going to have a radiologist in-house. You're not even necessarily going to have an ultrasound tech in-house. I was in Anaconda last year, and we had a patient who dissected her aorta, and it took 90 minutes to get the ultrasound tech just into the hospital. And that's simply because they're on call. They don't live close by. That's just the resources that are available in that environment. And sort of to get you thinking about utility of this, I do want to just present a few cases here, and we'll come back to them again later on. So a 19-year-old female, she comes in, she says, I have left upper quadrant pain. I have some rare genetic syndrome that you've never heard of. I went and looked it up, and there's like 600 people that have it. But bottom line, it's a connective tissue problem. She's had a spontaneous pneumothorax before. It says, this is what it felt like when that happened. She has normal vitals, so hold on to that. We'll come back to it. Another one, 34-year-old, 4 days of high fever, body aches. She's coughing up purulent sputum. She's short of breath. When you see her in the clinic, her vitals are fine. Put your stethoscope on there. Sure enough, her left lower lobe just sounds terrible. And then one more, 65-year-old female, history of chronic pain, depression, diabetic. She's had cellulitis multiple times in the past. She comes in. It's 5:30 on a Friday, of course, and she's got unilateral leg pain and swelling. You measure, sure enough, her left calf is bigger than her right. Maybe it's tender. She kind of always has pain, though. Hard to tell. So really quick, I mean, just for this first case, like, what's your one test you're going to do? Anybody? I heard a murmur of a chest x-ray. Right, so she's in the ER. She's worried about a pneumothorax. Even if her exam's okay, and even if her vitals are okay, with her history, you're going to get a chest x-ray. How about this next one, this 34-year-old? Chest x-ray, sure. And then the last one, ultrasound, which at least in our clinic, at 5:30 on a Friday, it's either going to be we send her home and give her like PE return precautions, which seems not great, or she has to go to the ER because it's the end of the day. And you know, after 5 here, we can't really send people for outpatient imaging. So hang on to those. We'll come back to them. All right, moving on to the physical exam. Just a few comments. We've been doing this for forever. Observation was a key part of it. You know, you sit there and you watch your patient die slowly and horribly of tuberculosis or whatever, and you write down your detailed observations. Obviously, this became more important as we developed actual treatments for things. I think what ultrasound adds, though, is at the bottom of that list there, observation, palpation, percussion, auscultation is direct visualization. And I'm going to argue that that is a component of the physical exam. Some limitations of it, and we've all struggled with this from being a med student on, they're non-specific findings. You know, so in that last case, a little bit of maybe some tenderness of the calf. It's a little bit swollen. What does that mean? You know, unrelated abnormalities, just incidental findings. I can't tell you how many times I've put the stethoscope on a young, healthy person and like, oh, you have a heart murmur. Clinical significance, unknown. And it's neither sensitive or specific for the most part. I mean, occasionally there's some really cool physical findings, something that's pathognomonic, and those are the things we always get really excited about, right? But by and large, in our day-to-day, it's not sensitive or specific. In light of that, I actually want to move on and just present. This is all stuff from the rational clinical exam, just about some specific exam things that come up. This is abdominal palpation of a ruptured AAA. All these studies, you'll notice, are pretty old. It's because we don't really palpate if we're concerned about a ruptured AAA anymore. Sensitivity is widely variable. You know, anywhere from 44%, this 97% was people who were operated on, so there's probably some selection bias there. But bottom line is it's not that sensitive, really. And we'll see that as well with ascites. So we've all learned the maneuvers, assessing for fluid. Here's our exam things that we do. And if you look at them and like likelihood ratio is 2, 6. Sensitivities, again, 0.6 to 0.8, specificity, about the same. I don't know, I just find this really interesting because I can tell you within seconds putting an ultrasound on there with essentially 100% sensitivity and specificity if somebody has ascites or not. All right, DVT, since we had that patient who was maybe DVT at the end of our clinic day. Again, pain, tenderness, edema, swelling, erythema, Holman's sign. These are all the things we learn. How useful are they really? This is again from the rational clinical exam. When you look at studies though, they're not able to effectively rule in or rule out a DVT on physical exam. You just can't do it. You know, 78% of people in this paper had pain when they had a DVT. 75% had pain when they didn't have a DVT. It's not awesome, is kind of my point. I got one more for you. So this is cholecystitis, history and physical findings. Again, looking at likelihood ratios over here, kind of all 1 to 2-ish. Sensitivities are okay. My favorite is rectal tenderness for cholecystitis. It seems fairly unrelated. But no sort of single physical finding is really getting you to your diagnosis. And so I mean, our history, our physical, it's this cumulative sort of decision making that relies on adding all these things together. So if we're worried about cholecystitis and it's right upper quadrant pain and nausea and vomiting and fevers, and you're adding all these things together, your likelihood ratio gets better. And in fact, clinical gestalt for cholecystitis had a likelihood ratio of like 25 to 30. So if you're a clinician and you do your evaluation and you're like, yeah, I think that's cholecystitis, that's actually pretty good. But usually, again, physical exam is not often completely diagnostic. So we order labs, we order imaging to support our clinical reasoning. But this is kind of what I want to get into now. But what if? What if we could just improve our physical exam? And not improve it a little bit, but improve it a lot. So this was a study done a while ago now, 2005. And what they did, you don't have to read all that. What they did is they gave some medical students some ultrasounds and about 2 days of training. And then they put them up against some cardiologists and said, go find abnormalities. Their gold standard was standard echo. And the cardiologists who were being studied were not the ones performing or reading the echoes. So again, medical students with 2 days of training and an ultrasound. And they were correctly able to identify 75% of the pathology, where cardiologists found 49%. And then it breaks it down to valvular lesions, et cetera, but it's pretty much all the same. Across the board, these medical students did much better with their point-of-care ultrasound and a little bit of training than very experienced cardiologists. Granted, they just had stethoscopes, but there's actually a lot of similar studies like this. There's studies coming out now about medical students with Google Glass, other sort of technology aids. And some of those are like students that have zero experience, and somebody's literally just sort of walking them through the exam with their nerdy little glasses, and they still tend to do much, much better. So kind of in that context, I want to actually get into some of the literature on some of these specific conditions. This is not comprehensive by any means, but these are certainly more common things you might see, and mostly because of that, they're more well validated because they've just been studied more. So this is on AAA, as I mentioned before. Palpation of at least a ruptured AAA is not awesome. This was a meta-analysis done, I think, in 2013. And this is bedside point-of-care ultrasound. And you look at these. Well, first of all, look at the dates. Again, all of those studies about palpation were a decade earlier. This is clearly standard of care now. But your sensitivities are 100% with the exception of this one, which was just slightly lower. Your specificities are also great. Remember those likelihood ratios of like 1.5 and 2, and you like look at these and they're 33 to infinity. It's significantly better. I did want to comment really quick. This meta-analysis I like because they specified experience of the operator, and this is something I'm going to kind of come back to multiple times. But here, these are emergency physicians, no prior ultrasound experience, but had a 7-hour didactic. Again, no prior experience, but had a 3-day course, 4-hour workshop. So training was, again, variable, but by and large, these are not experienced. They're experienced clinicians, but not experienced ultrasonographers. They had training from 4 hours to a few days, and again, like sensitivity, 100%. And just for comparison, by the way, they're not like comparing to each other. These are all done with either abdominal CT and radiology read, laparotomy if they were an unstable patient and were taken to surgery immediately, or a radiologist ultrasound. Just because we need some pictures, because this is a lot of words and I'm getting bored with myself. Normal ultrasound here, vertebral body. This is your aorta. This is your IVC. This is what you might see. These are pretty dramatic. I mean, these are big AAAs. This is sort of patent vasculature and then like intramural clot. All right, pneumothorax. Think back to that 19-year-old patient we saw in the ER kind of at the start who was worried about it. So this is supine chest radiography after blunt trauma. So your MVA, whatever other blunt trauma, they're on a backboard, they're in a C-collar, they're coming in, and you're like, I wonder if they have a pneumothorax. Let's get a chest x-ray. This data here is actually for ultrasound. Your chest x-ray data is down here. Sensitivity 28 to 75%. Not great. Ultrasound was actually much, much better. 86 to 98%. Again, positive likelihood ratio is pretty impressive, 30 to infinity. One comment I do want to make on this is they did not experience or specify the experience of the clinicians here. So I don't know, I can't comment on that. These were all prospective trials, however. And again, the gold standard they were comparing to was a CT identified pneumothorax, or if it was an unstable patient, when they put the chest tube in, if there was that rush of air, they said clinically that's a pneumothorax, and that's what we're calling it. So compared to CT or that chest tube placement rush of air, you're looking at sensitivities that are, I would argue, quite a bit better than just doing your supine chest radiograph. And I think if you talk to the emergency docs, they'll all tell you stories about some patient who had some incident or some trauma, and they like just didn't seem quite right, and they got a chest x-ray that was fine, and then they did a CT scan and there was a giant pneumo, and it was just layered out where you couldn't see it. I've had multiple ER docs here in a community tell me that story, so I know it happens. All right, this is maybe my favorite. Lung ultrasound for the diagnosis of pneumonia in adults. Meta-analysis from 2014. I was really glad I found this because I was looking at all this primary literature. I was getting really nauseated because I was reading so many primary studies. And they were all saying the same thing, basically. So to me, this was a good find. Gold standard here was CT and radiologist read. So again, I think we would all say yes, a CT scan and a radiologist saying that's an infiltrate, that's a pneumonia. Like we can call that a pneumonia, especially in the clinical context. The exams done in these studies were ultrasound tech or experienced ER physicians. And you're like, okay, ultrasound tech, we just said that they don't do point of care ultrasound. How are we going to count them? We'll come back to that in a minute. Pooled sensitivity and specificity, 94 and 96%. Again, a good positive likelihood ratio. I just want to come down here really quick. Chest x-ray is generally 60 to 80% sensitive and specific. And it wasn't in this study. There was a separate one that actually looked at sort of when you can call it an infiltrate and when you can make the diagnosis. And again, point of care ultrasound was able to detect pneumonias earlier if you follow those patients forward clinically and do serial ultrasound versus serial chest x-ray. So they said, okay, great, we have awesome sensitivity and specificity. Doesn't actually take all that long. The maximum time it took was 13 minutes in one of these studies. Let's break it down and see if it matters where that patient is, who's doing the exam, and it turns out it didn't. So they looked at ICU, they looked at emergency room, and then the general medicine floor. They also broke it down by ultrasound tech versus ER doc versus actually internist. And they found there was no difference in that sensitivity or specificity. So I think this reproducibility is really interesting. The fact that you're putting and again, they didn't specify training here, they just said experienced physicians. So I wish I could tell you they had X amount of imaging studies or X amount of training. I don't know that. But between ultrasound techs and experienced physicians, there was a ton of reproducibility in these findings. So I would almost wonder, instead of doing chest x-ray, should we, like, as a matter of routine, be sending all of our patients for thoracic ultrasound if we're worried about they have a pneumonia? I don't know, but it was a thought that I had looking at this. I think it's pretty compelling, especially if it's a quick exam and it's nearing the sensitivity and specificity of a CT. Again, this is not about how to do it, but just here's a few things that you might see. These are sort of abnormal artifact. We call them B lines, and they're indicative of some kind of pathology. This is your little pleural lining here. Yeah, we're not going into that. Anyway, this is abnormal. Air does not conduct ultrasound well, and so when you see these sort of lines, it means that there's usually some kind of fluid in the parenchyma itself. And this is what you would see if there is fluid outside the parenchyma. So this is your liver, kidney, this is your diaphragm sitting here, and this is just a little bit of pleural effusion kind of sitting there right on top of the diaphragm. All right, DVT. So our old lady, she's got diabetes, she's got chronic pain. She's got a swollen calf, and we're like, it's the end of the day. Do I make this person go to the ER and get an ultrasound? So tons and tons and tons of studies about DVT, varying from 2-point ultrasound, which I'll talk about in a second, to sort of full vascular imaging. The 2-point ultrasound, I have a picture here. So the two-point compression test is probably the most common emergency room test. All you're looking for is collapsibility of the vein. So common femoral artery, no compression, common femoral artery, and then your vein with compression is not collapsing. That means there's clot in there. Acute clot is made of blood, so it's not going to look any different than blood, which is why you do compression. So the 2-point is looking right here in the common femoral, and then right here in the popliteal, and you usually go down to where it trifurcates. Just so you guys understand what we're talking about when we're talking about 2-point compression. So 2008, prospective randomized study, first episode of suspected DVT of the lower extremity. And this was a nice study because it was randomized to undergo either 2-point or the whole leg with an ultrasonographer. And they basically found no difference in the rate of DVT. So the authors of this study concluded they were equivalent diagnostically. And I think there are a few weaknesses with that. It's making a little bit of a leap. But I do find it interesting. They were saying, okay, 2-point ultrasound found this, X amount, this percentage, and that was the same as the whole leg. Therefore, we're not missing any. So then another one in 2010, this was prospective and sequential, meaning the patient came into the ER, you suspect DVT, your ER doc does an ultrasound, documents what they think, then sends them to radiology who documents their exam. 200 patients, and they basically found, fairly dramatic results. 2-point compression had 100% sensitivity and 99% specificity, again, when compared with a follow-up ultrasound in the radiology department. All right, so then 2013, same thing, ER physicians compared to a formal radiology department, ultrasound or actually angiography. This was a meta-analysis, 2,400 patients, which is 16 studies, pretty good sample size. Mean sensitivity was 96 and 96 for specificity as well, so a little bit less than that previous one, but still pretty good. Actually, still really good. This last one I think is maybe sort of the most interesting or the most pertinent. It was retrospective. It came out just a couple years ago, and it was, again, ER physicians versus formal radiology. And they found that 6.3% of DVTs were not in those two spots we just talked about. So where they're compressing, they found no clot, the ER docs did. The radiologist didn't either, but then because they were doing the whole leg ultrasound, they found isolated clot somewhere else. So whether it was the deep femoral or just in the femoral vein, but not here and not here. That had an incidence of 6.3%. Correct. It's strictly compressibility. So you might say, okay, we're missing 6.3% of DVTs, and that's bad because DVTs can cause PE. So I think though that's not a valid critique of doing a 2-point compression because there's lots of data that we have good sensitivity and specificity, at least in the 90s consistently across multiple studies. I think how I would interpret this is if you have a really high clinical suspicion and you do your 2-point compression ultrasound, just keep on imaging. That's the nice thing about point-of-care ultrasound is it's real time. And if you're like, I looked in the common femoral, I looked in the popliteal, but gosh, their leg's swollen, it's acute, it's painful, they just flew in from Delhi, whatever. You can image that deep femoral or down the femoral. You can do the whole thing. And if you're still not sure, send them for a formal study. So I would interpret this as not a limitation on your 2-point compression. All right, gallbladder. We're nearing the end of like this thick, just dense data. So this was ER bedside ultrasound for identification of gallstones, retrospective analysis of a ton of studies. And the comparison was, again, this was sort of a sequential, so ER physician and then a formal ultrasound. They specified some experience. It was attendings, it was residents. We don't know how much training they had. The ID of gallstones, the emergency physicians were 88% sensitive and 87% specific. Again, this is compared to a radiology study. This is just the table just breaking down some of the studies in their meta-analysis, but pretty comparable, generally 80s to 90s for sensitivity. Let me see if there's anything else I wanted to say on that. Nope. So this is what you might see on that study. Gallstones, sludge, gallbladder. So this one is actually a little bit more interesting. I think this is actually cholecystitis, so an infected gallbladder. This was prospective from 2010, clinically suspected cholecystitis, which, as I said before, if you think it as a clinician, 25 to 30, your likelihood ratio is 25 to 30. So that's pretty good. This was, again, sequential. So ER doc did the ultrasound and sent them to radiology. I think the most interesting part of this study and why I included it is the gold standard was not radiology. The gold standard was we send them to surgery and we take out their gallbladder and then send it to pathology, and if that's consistent with cholecystitis, that's our diagnosis. And when you look at it that way, you actually see that the EP docs and the radiologists were very, very similar. I think if you had compared just to radiology, you would have seen that difference again of like, oh, we're missing some. The radiologists are detecting more. But when you actually have them compared to surgical pathology, they're pretty much identical. I've seen this study actually quoted in a lot of different places because of this reason, that our gold standard was not a CT scan or a radiology read. It actually was surgical pathology. Here's another one that was from Turkey, which was interesting, but they actually gave surgeons the ultrasound and found that they were pretty good, apparently in Turkey. And this was a quote from the study, but it's hard to find a radiologist on the weekends or in the evenings. So they didn't specify what kind of training, but I think it's a reasonable thing when we're talking about point of care ultrasound to think about who else might be doing it besides the emergency physician. But they found that by and large the surgeons were able to detect cholecystitis acutely pretty well. This is what it might look like. So this is liver, pretty normal gallbladder here, and then when it's infected, you just get this sort of chewed up edematous wall. Sometimes you can actually get little bits of fluid around it, and the wall just gets really, really thick. So that's kind of what you're looking for. All right, back to our cases. So we said chest x-ray for here and for here, and then this was like, yeah, we should get an ultrasound, but do we have to send this person to the ER? Is that really worth it? So, I mean, based on what I presented, does this like change anything? You know, so pneumothorax is her concern, and you do a chest x-ray and it's normal, but you have your bedside ultrasound because she's actually coming in complaining of left upper quadrant pain, and you do that and that looks normal, and you keep on scanning, and lo and behold, you find a 17-week pregnancy. This next one, 34-year-old, left lower lobe, like focal findings with your stethoscope, throw the ultrasound on there, sure enough, findings like what we saw, just obvious pathology. This is outpatient, clinically stable, but maybe now and flu negative. You know, you treat with your Z-Pak instead of just saying, it's a cold, go on home, you'll get better. And this last one, again, now we have a linear probe in clinic, which is appropriate for a DVT scan. but doing a two-point compression ultrasound would be a pretty valid option. You think this is a low-risk person, if you can say, yeah, you had a 2-point that was normal, and send them home, it's probably pretty reasonable, which is what happened. And then phone follow-up the following week, her symptoms had just disappeared and she was fine. All right, so this is I think worthy of a little bit more discussion in terms of sort of the caveats of this. There is a learning curve. Taking training courses is a good idea. There's actually a ton of information online. There's something called free open access online medical education, which has a ton of stuff in POCUS on it. But there is a learning curve, and you need to know your limits. You need to know your limits of scanning and your limits of interpretation. For me, I'm really comfortable looking at the gallbladder. I'm really comfortable saying you don't have gallstones, or saying I can't actually see it very well. I can't really comment. Looking at the common bile duct, don't ask me to do that. Knowing your limits, it's something that we all have to do anyway with all of our physical exam. My neurologic exam is not the same as John Schaefer or Sherry Reed doing a neurologic exam. It just isn't. So I think it's really important to know kind of when you can really apply your point of care ultrasound and say this is helping me diagnostically, this is helping me answer clinical question, versus when it isn't. Interpretation is also really tricky at times. So I don't do any kind of like thyroid point of care ultrasound. It's super easy. I mean, the thyroid's right here, a linear probe. You can see the whole thing, no problem. But what does it mean if you find a nodule? I don't even want to go there. That's something that I think the endocrinologist can manage. You know, what the incidence of thyroid nodules that are just there and not doing anything is really, really high. So that's for me why I think interpretation of it is a limitation of point of care ultrasound. Credentialing and documentation. This is something that as our program has sort of moved into trying to develop point of care ultrasound is come to the forefront. You know, how do we train residents, and how do we say as a program this person is competent to do this exam? Maybe they've done 10 and they're really good with an ultrasound and that's enough. Maybe they've done 100 and they're kind of crappy with their like spatial orientation and that's still not enough. Like how do you suss that out? I think that's really challenging. How do you document this? Pictures are great, video is great. We don't have like a PACS in our clinic. So what do you do? For me, a lot of times it's actually putting it in the exam. It's thinking about this. This is like a stethoscope. This is like a reflex hammer. This is like a physical exam maneuver. And, you know, documentation. So 19-year-old comes in with concern for pneumothorax, point of care ultrasound, identifies single intrauterine pregnancy on abdominal exam. You can date it based on your fetal biometry, and that just goes in my abdominal exam. And then, you know, she can have an outpatient follow-up and whatever, at least in the emergency department. But documentation is a challenge. Credentialing is a challenge. Training and application is highly variable, and I'm going to talk a little bit more about that right now. So I did try to include as much as I could, like I mentioned, the level of training in these different studies. That AAA study, it was 2 or 3 day courses for the most part. The cardiac study was med students who had 2 days of training. The pneumonia meta-analysis, they didn't specify, but they did find no difference between the docs and the ultrasound techs, and the same with the gallbladder. There actually was a study looking at this, looking at like, what if we just give people an ultrasound, again, back to the 2-point compression, what if we just give them an ultrasound and like see what they can find? So this was a prospective sequential study with ultrasound naive emergency interns followed by a radiology evaluation. And they found that really with no significant training, they literally had a couple hours of training. They'd never used the ultrasound before. They had a pretty significantly reduced sensitivity, 57. Again, remember, like before when we were looking, they were consistently greater than 90. And so this was with a couple hours of training. Like, oh, that's actually not great. So, I mean, I think the conclusion is train more. I don't know what else I was going to say on that. I don't know. I think it's still pretty interesting, though, that with very little training, you can still find significant pathology. There's a lot of standardized protocols coming out. We've all heard of the FAST exam, right? You know what that is. But you may not know there's other ones. There's BLUE, there's CLUE, and there's RUSH. RUSH is rapid ultrasound for hypotensive patients who are non-trauma patients. It's been around for about a decade now. But it's like a very, very specific protocol. These are the probes you use. These are the views you take. And this is what you're looking for. And it's very specific etiologies, very specific pathologies. Again, this has been pretty well studied in the emergency department and in the ICU. There's not a ton of data on it in terms of how it affects outcomes at this point, or it's hard to find. I don't think we just don't know yet, but by and large, I would say standard of care, if you went and talked to Will Serber or Dan Prop, I mean, they're every day they're putting the ultrasound on people to make this kind of assessment. That's us. So our program, obviously, we've been around for, you know, basically 5 years now. This was the ultrasound that was in clinic, a little M-turbo sonocyte. We used it primarily for obstetrical exams. Just this last year, we got the sonocyte export, which props to the program for supporting that, and props to the clinic for making that happen. So now we have 2 machines. This last year was sort of the first year we kind of started really thinking about formalizing the ultrasound education. So there's now slots in our intro to residency block, just sort of doing an intro to ultrasound as well. There's 4 didactic slots throughout the year on our Wednesday afternoon didactics dedicated to ultrasound. The faculty are actually just now doing a training course. And this is something I do want to comment on, because kind of across the board, emergency residents are far more comfortable with ultrasound than some of their peers, or not peers, their attendings who are clinically extremely experienced. It's a paradox of you have these clinicians who are very experienced and don't ultrasound, and these trainees who don't have the experience but are like, hell yeah, let's throw that probe on there and see what we can see. How do you find that balance? And some of it is training your faculty, and then, you know, alternatively, it's just having your residents go elsewhere for that training. There's multiple residents that are using CME time to take courses and learn about ultrasound, and we're actually getting Dr. Paddock is getting a little handheld unit to practice with as well. I did want to comment on briefly kind of what the EPs are doing, the emergency physicians, in their training. So since about 1990, their national college has supported use of point-of-care ultrasound. It was sort of growing and growing, and now it's an ACGME requirement for emergency medicine programs that they have to have point-of-care ultrasound training, you know, X hours a week, X amount of studies. There's 95 fellowship programs nationally now in point-of-care ultrasound, specifically for emergency physicians. And interestingly, when I talk to my colleagues, when I talk to my friends from medical school who are in like IM residencies and stuff, they're actually getting point-of-care ultrasound training from their peers in the emergency department. So when you're at a big academic center and you're in the MICU or the SICU and you're mixing your medical intern versus your emergency intern, those emergency residents are training their internist colleagues. They're training their FP colleagues. That's anecdotal, but I think it's probably happening a lot. A couple other comments. Medical students, first year anatomy courses are now incorporating ultrasound. The AAFP has a draft curriculum in the works for family practice docs. And the AMA has also sort of given its blessing to expanding the use of point-of-care ultrasound. So here are my conclusions. Traditional physical exam is fine, but I think it can be a lot better. I think you add that visualization component and you can answer a lot more clinical questions, perhaps without formal imaging. I think that's really well validated. Again, lots of examples, especially from the emergency department in common clinical situations. I think as we just do more and more studies, we'll have more and more clinical scenarios that are validated. And training of med students and residents should be routine. I think it is in some places. The emergency department, again, some programs have their med students pulling the probe out with their anatomy course. But I really think it should be routinized because it adds so much more ability clinically to make decisions. And I just wanted to come back to this critique, which in context is that the stethoscope will never come into general use. Notwithstanding its value, I'm extremely doubtful because its beneficial application requires much time, gives a good deal of trouble to everyone, and because its whole hue and character is foreign and opposed to our habits and associations. And this is from a while ago. I think it's inevitable that the ultrasound is going to be like the stethoscope. You know, if you can take an iPad and a probe into the bush in Africa, you know, you'll never get an X-ray machine in there. You'll never get a radiologist in there. Like, I mean, I think it's just so just broadly useful in terms of helping us with our clinical reasoning and our clinical diagnosis. And I have a few references. So, questions? It's okay if you don't have questions. All right.
Just to say, ultrasound is amazing in terms of enhancing the physical exam, but having done point-of-care ultrasound now for a number of years, I see a lot of residents and medical students, you know, they just jump to the ultrasound machine, and that's great, but when the ultrasound machine is broken or it's not working, you still got to do the physical exam. So I think it's really, really important as we teach our learners point-of-care ultrasound, we also teach them the physical exam, and to do both together. There's a comment I had.
I would just agree with that completely. I think, again, it's asking that focused clinical question of like, gosh, they feel bloated, and I push on their belly and I can't quite tell, and then you move on and pull out the probe and look for ascites, or you listen to their lungs and you're like, boy, that one focal finding that sounds terrible. Then you pull your probe out. So I would agree. I think it can help guide your use of it.
Can you tell us situations where using the ultrasound led clinicians to the wrong conclusion?
I'm sure I can. I'm sure there's many. Again, I don't know if you were in here for that slide earlier about how your 2-point compression ultrasound will miss about 6% of DVTs. So you could conclude based on that this person doesn't have a DVT, you could send them home and they have a massive PE. You know, it's not perfect for sure.
I just wanted to comment on the physical exam. I think there are a lot of situations where the ultrasound can actually enhance elements of your physical exam. For example, you palpate an abscess, or you think it's an abscess, and you look on the ultrasound and it turns out the abscess hasn't formed yet, and so there actually isn't flexion. So it gives you real-time feedback of your physical exam. Muffled heart sounds, is there an actual pericardial effusion? So it doesn't replace the physical exam. If anything, it gives you more information as to what you're actually seeing, feeling, hearing.
Nick, good job this morning. Could you tell us a little bit about patient education? I can see this being challenging for patients to think, boy, they use an ultrasound so they saw everything's normal versus a targeted exam. Yeah, I guess that's maybe the main way, but could you talk a little bit about that?
Sure, and I know we've talked, again, kind of with credentialing, we've talked about this a little bit, but what do you tell the patient? And I tell them that we can take a look, that I'm not an expert, that this can help perhaps answer a question for us, whether that's, is there a DVT, is there an abscess? But I think patients are generally fine with that. I don't think they're, I don't know, they don't seem to have expectations in my experience. When you are in the clinical setting and you roll in with an ultrasound, I don't think a lot of them really get that. They're like, oh yeah, I had one when I was pregnant. And that's perhaps all their experience with it. I do think that some of the onus is on the clinician in terms of, again, am I comfortable with my exam, with the ultrasound, in being able to rule in or rule out whatever it may be. And so if you think it's an abscess and it turns out it's just a cellulitis, you see no kind of organized fluid pocket, what I would tell them is, yeah, I feel really confident there's nothing here we need to drain. But maybe you're not that confident, in which case you say, gosh, I don't know, I can't see, we should send you over to St. Pat's for an ultrasound. So I think a lot of it is on the clinician and just using it like your physical exam. I don't think it sort of changes the dialogue.
60 years ago, a company called Corbin Farnsworth developed an instrument which was a little smaller than a washing machine. And what you did is you took the probe and you held it on the side of the head. And you saw a line going across an oscillographic screen, and you could see the left side of the skull, the right side of the skull, and you could see the midline of the brain, or if it wasn't in the midline, you could see how much it was deviated. We didn't hear anything about using point of access for intracranial things, but perhaps you can share that with us.
Yeah, it's tough on adults. I will tell you, we use it for babies that are still in the womb, and we use it for neonates. You can image through the fontanelles, one after birth. And in adult, you have bone, and bone is really not something we can image through. The skull is fused into one piece, and that's one of the limitations of ultrasound, is you can't really image through the bone. So seeing into the skull isn't really, I think it'd be great, because how many head traumas come into the ER and we're like, I don't know, whatever, CT scan, rule out bleed. We could save them that, but we just can't with ultrasound. That's one of the sort of physical limitations of it.
Nick, I'm wondering, one of the sort of arguments that you often hear made about point-of-care ultrasound is sort of, the potential for unintended consequences. And I'm wondering, as we're talking about sort of the wider proliferation of this technology, we know a couple of things about, application of diagnostic tests, and that, the performance of the test depends a lot on sort of the prevalence in the populations. We're talking about looking for things, in the outpatient in the clinic setting versus in the ER where the acuity is higher, for one. And also just, I wonder a little bit about sort of the incidentaloma problem. There are obviously real legitimate harms that we all worry about with, chest TTs for lung cancer screening and other things where we're all of a sudden doing this in a whole bunch of people, and we're going to find stuff that we're going to work up, test, do other things to, some of which, like the pregnancy, might be a good thing that we found, but some of which we may not. So I'm wondering if in your kind of review of the literature, if those questions are being addressed yet.
Yeah, and that's a great question. I think the answer to it is to have yourself in the frame of mind of, this is not a diagnostic ultrasound. And the difference being, if I say ultrasound abdomen, they look at everything. And the question is, do I think this person has a gallstone with their typical presentation of biliary colic? So I think you can, and these questions are raised in the literature, but I think you can avoid that sort of overdiagnosis by not doing that broad imaging, by not screening per se. That's, again, why I avoid ultrasounding the thyroid. It really is, I have a history and I have a physical that makes me very worried about X. If I look directly at X, I can answer this question. And so I think it's rare that you're going to be saying, I threw the ultrasound on there and incidentally finding a pregnancy. That's going to be pretty unusual. Does that answer your question?
I'm wondering if, kind of thinking about cost savings, if the findings on 2-point ultrasound are basically just as good as sending for a full leg or to a specialist, what you think the potential is for cost savings if you came across how many times we send somebody for abdominal CT for workup of potential cholecystitis, and how frequently it's positive or negative, or would a surgeon take, if you've just looked with point of care ultrasound, would they, and you say these are my findings, would they go straight to the OR, or are they still going to want that abdominal CT?
Good question. I didn't mention this, but there are multiple studies, again, from the emergency department, looking at time to treatment and looking at cost savings, and they're generally positive with point of care ultrasound. I think by and large, there's something of a relational trust component as well. So if one of our ER docs that's done a lot of point of care ultrasound calls one of the surgeons and they know each other well and says, here's my clinical history, here's my exam. Yeah, I looked at the gallbladder and boy, it's just a fat, nasty edematous wall, and there's pericholecystic fluid, and there's a big gallstone in there and sludge. I think that the working relationship between those two docs is such that they would be fine with just saying, yeah, let's admit them, and whether they operate right away or not, I don't know. But I think it's easier to think about it in the abstract. Well, what if some emergency doc is calling some surgeon that they don't know, and then we imagine there might be some communication or question of is this good enough? But I think the reality is, at least in this setting, it's small enough that the surgeons and the ER docs know each other and will trust their clinical judgment, or maybe not.
I think we are probably out of time, but I think Nick will be happy to stick around and answer any questions you might have. But thank you for that great talk.